Good afternoon, everybody, and welcome back. I know it was a very short lunch break, but we've got a great session to continue our conversation on equity and health disparities. So I'd like to introduce Dr. Julie Sinjak, who's one of our voting members on the council, who will be moderating this afternoon session. Julie, the floor is yours.
Thank you so much. I'm delighted to moderate this session and very, very excited to hear our four presenters today who will give three presentations and continue what I think is a critically important discussion that we started this morning. So I'm going to go ahead and introduce everybody now and have them go back to back so that we have plenty of time in our Q&A to get everybody's questions. So first we'll hear from Dr. Consuelo Hopkins-Wilkins from Vanderbilt University Medical Center, who will talk about addressing Black and Latinx health disparities during a pandemic. Then we'll hear from Lieutenant Commander Tyler Campbell and Captain Tammy Rodriguez, who will speak about the COVID-19 pandemic and antimicrobial stewardship in the Federal Bureau of Prisons. And finally, we'll hear from Dr. Jonathan Iralu, who will talk about addressing antimicrobial resistance in the Indian Health Service. So I'll go ahead and turn it over to Dr. Wilkins. Thank you so much.
Thank you for the invitation. So just a little bit more about me. I'm the Chief Equity Officer at Vanderbilt University Medical Center. My background is in internal medicine and geriatrics, and I lead and oversee a number of programs focused on health equity at our institution. So next slide, I'm going to start with sharing just a little bit about our strategy for addressing inequities in COVID-19. And then I'll go into more about pandemic preparedness broadly. So early in the pandemic, so this is April 2020, when our institution, like many others, were putting together their command center operations, the center of focus for addressing COVID-19, our CEO asked me to put together a work stream, join the command center, put together a work stream focused on health inequities. So certainly we were starting to see already inequities in COVID-19 around the country and wanted to be prepared there. So we put together a team to really think about how we would, in a systematic way, approach these inequities. So identifying the need for effective communication, embedding equity into testing and care, but also given that this was a new disease, how will we make sure that there's inclusivity in the clinical trials and participation, and then thinking as well about some of the unintended consequences or downstream consequences of things like shifting to telehealth. What would be the impact on equity in those populations that we know are marginalized and minoritized? So next slide. We've written about this, and again, not necessarily completely unique, as many other health systems did something similar, but within our approach, we spent a lot of time thinking about how we would identify as precisely as possible inequities, and so that we could actually have a strategy, an implementation strategy to address them as completely as possible. So a lot of that focus was on using best available data. So this graphic here is really showing you the zip code. We identified the zip code amongst our patients that had the highest rate of COVID-19 inequities. And so this is zip code in the southeastern part of Nashville, for anybody who's familiar with the area. And we wanted to compare and contrast that with the rest of the Nashville metropolitan area. So looking at that zip code in the table on the right, you can see that this was an area of town where there was more diversity. So more people in the area who identified as Black or Hispanic, Latinx. This was individuals who were more likely to speak a language other than English at home, more likely to be born outside of the United States. They actually had higher rates of employment, so they're more likely to be working, but had a lower income and more likely to be living below the poverty line. So the next slide. So, we looked at that broadly and thinking about, again, what do we know and how can we put together programs focused on communications, testing, care, as well as, inclusion in clinical trials based on what we were seeing in the population in real time. So a really key and important strategy for addressing inequities, again, looking at the data and, of course, relying on sociodemographic data like race, ethnicity, and language data. So we were intentional in disaggregating data by these different factors. And so you're looking at one of the reports, we were giving these initially multiple times a week. My team was disaggregating the data by race, ethnicity, and language and reporting these to the command center. And then as the pandemic went on, we started to decrease the frequency of these reports, but we still are disaggregating data and following them as we continue to see COVID-19 as well as influenza and other infectious diseases around this time. So what you're seeing here, again, we are comparing, and so that's important. You know, what are we looking at? Not just looking at the data, but how does that reflect our local populations? In conversations with colleagues around the country, again, thinking about, okay, if you're comparing your local demographics and rates to a national average, that's not necessarily what's most important if you're living in an area that has more or less diversity. So again, we try to be really precise with identifying these inequities. And I highlighted here unknown race, because as many of you know, especially early during the pandemic, a lot of the data we were seeing did not have race or ethnicity. People were not reporting it, they were not capturing it. And so we think it's important that those folks are not lost or missing, that we actually are looking at them as a group. And not dissimilar from some other reports, we've found that people whose race is unknown or missing actually have more disparities, more inequities. So that's an important piece, that you're not overlooking or leaving behind groups just because you don't have that data. Next slide. Similarly with language, so one of the first disparities or inequities we saw locally was amongst people whose primary or preferred language was not English. And we actually have a relatively small population of Nepali-speaking people in the Nashville area, but at one point, and that's reflected here in this slide, they had really the highest percentage positive within that group of any community. So we actually had to work with community organizations, community partners who serve and know that population, to make sure that we were communicating with them, understanding some of the barriers to them getting tested and using some of the preventative measures. So again, I would emphasize, especially as we know, many of these groups, or most of these racial and ethnic categories, have subgroups, and understanding how to communicate with them, understanding cultural differences. There's more heterogeneity within groups of people who identify as Black or Hispanic, Latinx, than perhaps between those groups. So these are not, monolithic groups, and thinking about them as how do we best understand more at the individual level is also important. Next slide. So of course, one of the first questions people started to ask, why are people from these racial and ethnic groups that have been minoritized disproportionately impacted? And many of us seem to be surprised, but we should not have been surprised. And so this is a graphic from 2008 with influenza, really highlighting these socio-demographic positions that people have and how that actually increases disparities. So we should not have been surprised. We should be prepared. We should have been prepared. We should be prepared in the future. So wonderful that you all are thinking about this. Next slide. Taking a little bit of a deeper dive into these social determinants, I did want to highlight that race is a social construct, and often in the United States we are using race and Hispanic ethnicity. The way that we capture race and ethnicity by OMB categories, we're not capturing ethnicity. We're just capturing Hispanic ethnicity. And so in my mind, that in itself as a really racist way of capturing that information. To have people identify as Hispanic or not is really not a complete way of understanding different ethnicities. But as a social construct, we have to recognize that there are societal implications when we put people into these categories that don't have a biological or genetic basis. And often underlying that are racism and systems of oppression that really lead to these different opportunities and segregation and likelihood of being employed in certain ways. And so I'll point to you in the middle here, this in the psychological stress. So, experiences with racism and discrimination have a physiological impact. So increasing allostatic load leads to changes in immune function, inflammation, and these all have an impact on your likelihood of susceptibility to infectious disease and other chronic diseases as well. So it's important as we think about these categories and groupings of people as racial or ethnic groupings, that they are not disconnected from the environment, the social factors, and those things need to be considered. And so not just thinking about, healthcare utilization and how do we educate people, there certainly are these upstream factors that we have to think about. Next slide. So I had the pleasure of working with two colleagues early in the pandemic to think about equity, and here are some tables from a paper that we published in December 2020, really thinking about how we could be better prepared. And so I won't really go into detail in these, but wanted to include some snapshots in the slides here so that you can reference them. But those upstream factors, so what are those social and structural factors that are increasing the likelihood of people being exposed to inequities or likely to experience inequities, and how can we address them? So a lot of that is, again, focused on the infrastructure, the public health infrastructure, where are resources, how are we, making sure that communities that are most impacted by inequities have their fair share of, stockpiled materials and masks, and of course, access to rapid testing. There are many other things that are perhaps beyond the scope of your council to address, but making sure that you understand and are cognizant of that. If we're not addressing those, we'll continue to have these inequities as well. Next slide. And as well as some of the downstream factors, which perhaps, more in the control of the healthcare sector. I would continue to emphasize, effectively communicating health risk. We spent a lot of time thinking about, who are the trusted messengers? How can we partner with community organizations? As we partner with these organizations, making sure that they have resources and compensation, and we're not just shifting the burden of doing all of this work to them, especially during the pandemic when we saw many of them suffer from less revenue, fewer donations, and really an increased need to serve their communities. Thinking about how you implement this in socially and culturally acceptable ways, appropriate ways that are decreasing stigma, the idea that people are being tracked and traced in general when they've been marginalized and persecuted in the past is not necessarily the right language. Again, and thinking about, how will we have access to care and services, including testing. Next slide. Just specifically, I know there's been a lot of discussion about, antimicrobial resistance and disparities and how much is there, where, the data may be contradictory at times. There's certainly data that shows that there are racial disparities in MRSA. That's what we're showing here. And I think, again, linking race to recognizing race as a social construct and linking it to these socioeconomic factors, living in communities that have been disinvested in, fewer opportunities. That's what you're seeing here as well. So people who are living low income households, crowding, all of those things have an impact on likelihood and risk of infectious disease disparities. So making sure that you're disaggregating data not just by race, ethnicity, and language, but thinking about those social and economic and other structural factors. Certainly there's lots of data as well. Internationally, countries that have lower resources certainly are seeing more antimicrobial resistance and some of the same issues that we're talking about here are also issues for them. Next slide. So with just a few recommendations, if you're taking recommendations from my standpoint about how to prepare in an equitable way to address these disparities and thinking about pandemic preparedness. So just always remember that our health systems are built on structures of inequities, long-standing inequities, racism, structural racism, embedded into the structures of our health system, segregated care, not, accepting, people from minoritized groups into medical school, nursing school, PhD programs, lots of things that we're trying to build and create equity on this foundation, on these foundations that were not equitable. And thinking again, making sure that we're not assuming that any differences we see among racial and ethnic groups are due to some biological differences. Yes, our interactions with the environment, experiences with racism and discrimination have an impact on us biologically, but that's not because of an inherent difference. Again, thinking about strategies that address both up and downstream factors, effectively communicating, and then I would end saying just, recognize these hidden inequities, especially as you start to, if you're seeing times where people from minoritized racial and ethnic groups might have lower rates of antimicrobial resistance, remembering that, of course, they have limited access to care, less access to care, less likely to have commercial insurance, does not mean that that is some protective factor. We want to make sure we're not romanticizing the fact that people who don't have access to care and are dying from cancer and heart disease, that we should just be happy that they're not having more antimicrobial resistance. So I will end there, and thank you again for the invitation.
Thank you so much. And now we'll hear from our next speakers. Good. Take it away.
Okay, thank you. My name is Tyler Campbell. I am the Chief Pharmacist at the Federal Correctional Institution in Elkton, Ohio. And with me today is Tammy Rodriguez, who is the Chief Pharmacist for the Federal Bureau of Prisons. She will be available with the question and answer portion today. I will be doing the presenting today. Next slide. All right, so the objectives for the presentation today, we're just going to provide a brief history of the stewardship efforts within the Federal Bureau of Prisons, and after that, kind of identify some of the unique challenges that we faced during the COVID-19 pandemic, and then briefly touch on how those challenges of the pandemic affected our antimicrobial stewardship efforts in the Federal Bureau of Prisons. Next slide. Just a few background population statistics. There are 121 institutions in the BOP and approximately 145,000 inmates in our custody. You can see the demographics there. The majority of our patients fall between 26 and 50 years of age, and ethnicity data is there as well. 95% of all of our inmates will return to their communities. So in a lot of ways, from a healthcare standpoint, we are preparing these individuals to for release when they head back into their communities, trying to provide the best healthcare services that we can. Next slide. So In particular, healthcare in the BOP, we are one of the largest unknown health systems in the U.S. We operate like most health systems. We have a medical clinic at every BOP facility, provide services from physicians, mid-level providers, pharmacy services, dental services, have a lot of other ancillary services, including radiology, lab. We also use like referral to specialists, outside specialists. Some facilities have specialists come in to their facilities every now and then. So again, operate just like most health systems in the US. We are broken down by what we call care level. You can see on the slide that Care 1 would be the healthiest of our patients, those that are less than 70 and generally healthy, might have maybe one or two real minor chronic health conditions, but can easily be managed with a minimal health services staff. Care Level 2, that makes up the majority of our patients. These are your stable outpatients, so stable diabetics, hypertension, those type of chronic disease states. Care 3s then have a little bit more complex medical needs, and Care 4s would be our more inpatient facilities. So a lot of times, like individuals that need dialysis might need a prolonged hospital stay. We have a handful of those facilities as well. Next slide. So real quick overview of stewardship efforts within the Federal Bureau of Prisons. In 2013, our first internal antimicrobial stewardship clinical guidance document was published. And then about a year later, a advisory group was formed for antimicrobial stewardship. And it was originally consisted of 8 pharmacists and expanded to 12 over the course of 5 years. And really what we did was mainly just surveillance. We would just look for trends, identify things that might be concerning, and then provide information to all of our health services providers. So not a whole lot of authority, but more just kind of looking at where we might need some work and kind of providing information to the field. In 2019, we took the step of kind of formalizing that advisory group into what we call one of our clinical pharmacy consultant programs. So we formed one of those for antimicrobial stewardship, and what that did was gave us a little bit more authority to do some interventions and kind of focus on some things. And so that's where we currently stand. Is the program that we have. It consists of 12 pharmacists that cover all 121 institutions. Some of the interventions that we do, we provide some prospective audit and feedback on select broad spectrum antibiotics. We're also responsible for approving non-formulary medication authorizations and requests, so all of those get reviewed by one of the pharmacists. So those are the main 2 things that we do now. Next slide. So focusing on some of the challenges that we faced during the pandemic in the Bureau of Prisons. The first one is stated on the slide here, the mission statement of the Federal Bureau of Prisons. And I highlighted protect public safety and appropriately secure and provide reentry programming for individuals in our custody. So with any decision that was made during the pandemic, we always had to understand that, that our healthcare decisions were within the context of making sure that safety and security were paramount in all of our decision making. So exacerbations of negative perceptions of care. So sometimes, it works both ways. It's questionable about, are we providing the best care that we can? And, we have national clinical guidance, we have medication formulary, and those things serve a purpose. They ensure that the healthcare that we give meets community standards, while considering, that we're using taxpayer funding efficiently, as well as, again, that main mission of the agency as a whole to keep the patient safe and secure. We definitely ran into a lot of concern with refusing to treat patients using medications lacking clinical evidence of benefit. So early on in the pandemic, a lot of possible treatments that were thrown around that might be effective in the treatment. As an agency, we didn't rush to quickly approve those, and again, would release national guidance. And so, we were just following what evidence was showing and what was provided at the national level. Also, the baseline status of a large percentage of our population, so just highlight there the physiological age versus chronological age. A lot of our patients in our care have lived very rough lives. They come to us and, they might not have had access to real great health care prior to coming to us. So again, their baseline health status is often not congruent with their actual age. So we do have several individuals who are kind of come to us at that stage of disadvantage. And then also health literacy of the population, that is also a big concern with our patient population. Next slide. The kind of general makeup of how the institutions are, everyone's a little bit different. And when we were trying to social distance, isolate, quarantine, a normal housing unit layout differs institution to institution. Some have cells that can be locked and are easy to quarantine and isolate others from other individuals. Some are more military barrack style housing where you've got 400 to 500 in open housing units, making it very difficult to isolate, quarantine for social distancing. And then also several institutions, do they have the space to put individuals for isolation, for quarantine? Where all would we be able to put individuals to, once again, keep them safe, keep them secure, but also provide them everything they need for daily living as well. Outside hospitalizations, challenging. One thing is staffing requirements. We require staff for all patients that are admitted to outside hospitals, as well as transports to and from institutions to hospitals. And then we also are required to follow up while these individuals are located at the outside hospitals. And then another big one that I think everywhere, not necessarily unique to the BOP, but just staffing and resources. There's certain posts because of the security institutions that have to be covered. So depending on staffing levels, those sometimes health services staff is pooled to cover certain places. And then we also want to make sure that we keep our own staff healthy, rested, and safe, not just the patients, but also keeping staff as well. Next slide, please. This was actually, versus a challenge, this was actually one thing that was a kind of a strength for us. We were recognized as our own jurisdiction, and the major benefit of that was it allowed for equal and efficient access to therapeutics as well as vaccines. Because of our institutions are located throughout the United States, this allowed us to not have to go through kind of state hierarchy of who was prioritized to receive vaccines or therapeutics. We were recognized as our own individual jurisdiction, and we were able to have access to those. And also, it was essential to making sure that the care that we were providing was congruent with the community. Next slide. So considering all those challenges, what kind of impact did we see on our stewardship efforts within the BOP? Early on in the pandemic, diagnostic issues, delays led to increased use of certain antimicrobials. We definitely saw a trend, an uptick in use of antimicrobials usually used to treat pneumonia. An example there said, we'd get an X-ray in-house, but waiting for results of whether someone was COVID positive, COVID negative. do we treat even though we have a pneumonia on x-ray, or do we not, knowing that there's a good chance it's viral? Balancing our stewardship goals with possibly effective treatments early on. Again, zithromycin is a good example, and trying to still limit use. And then competing priorities, as we said, with staffing issues, there's certain things that have to be covered, and they often presented challenges for infection control. Next slide. So throughout the pandemic, not just early on, but throughout the entire pandemic, healthcare staff time and area of focus, we had to have staff to test, with a lot of movement of our patient population, still ongoing now between institutions. They have to be tested, and it takes individuals to do that. If they get moved from isolation to quarantine, it takes loading up of all their property, and there's just a lot of legwork that goes into the movement of inmates, and that continues now to this day still. Vaccination efforts, both of our staff as well as our patients. Effective communication. Again, just kind of reinforcing what was necessary, that we're following what evidence shows treatments are necessary, and that applied to our patients, but providers as well. Just trying to get information out to the field, proved to be difficult, and presented some challenges for us for continuing to watch our antimicrobial use. Next slide, please. So in summary, several of our challenges were, similar to the rest of the community, but we did have some unique things when you consider the overall mission of the agency. We recognize that there were multiple new challenges, and often it was unique to having an incarcerated population. And our stewardship efforts were not immune to the effects, but we still do continue to implement the efforts that we have. Thank you.
Thank you so much. As a reminder, we'll hold questions till the end after this next and final presentation of the panel. Thank you so much. Go ahead, Dr. Irilu.
Thank you so much for the invitation to speak today. I'm John Irilu. I'm an infectious disease consultant for the Indian Health Service. Had the good fortune to work for the last 29 years at Gallup Indian Medical Center for the Navajo Area Indian Health Service. And I'm going to talk to you a little about how we in the Indian Health Service have addressed antimicrobial resistance, and particularly talk about some of the effects of the pandemic on the work that we do. And I should say that the views expressed today are my own and do not represent the views of the Indian Health Service necessarily. Also, I have nothing to disclose. Next slide, please. So a little background on the Indian Health Service, founded in 1955, currently serving about 2.5 million persons from a total of 574 federally recognized tribes in 37 states spread all across the United States. We admit approximately 40,000 patients per year, and we do about 13 million clinic visits per year in the Indian Health Service. And we're in a somewhat unique situation in American Health in that we provide primary care, we provide hospital-based care, we have specialty care, and we have full pharmacy responsibilities to the patients that we serve. And lastly, we are a public health service entity, so we take care of public health needs of the population that we serve. Next slide, please. So a little about the history of antimicrobial resistance. It started off for us in 1997. So the concept of community-acquired methicillin-resistant Staphylococcus aureus, sometimes called CAMRSA, C-A-M-R-S-A, first showed up in the United States around the year 1997, and it was actually in an Indian Health Service facility. Around that time in the Indian Health Service, in this particular district, 55% of the first 112 patients who had Staph aureus isolated from cultures had resistant organisms. So over half were MRSA, something that was not seen in the United States before. This was spread in the community, not based just in hospitals. And an early paper by Dr. Groom and others published in JAMA showed that the risk factors were identical for this community-acquired infection and the regular non-resistant Staph aureus patients. Next slide, please. So how do we respond to this? Back then in the late 1990s, we did an internal analysis and we discovered that overprescription of antibiotics was linked to this commersa infection. This was a novel concept at that time. And we decided to provide report cards to individual providers in this district where there was a problem, and showed that providers who provided antibiotic prescriptions more frequently had higher rates of commersa in their patient panel. For instance, if a person only gave out one antibiotic prescription for every 25 patients, they would have very low risk of their patients acquiring this infection, whereas someone who gave out 5 prescriptions out of 25 visits would have a much higher risk of this bug, commersa, showing up in their clinic. Armed with this, we did lots of educational activities. We did some local continuing medical education on the spot in the highest risk area. We educated our Indian Health Service leadership, and we also started teaching about the concept of drug resistance back in the late 90s at the Indian Health Service Primary Care Conference, an annual continuing medical education meeting. Next slide, please. So what do we do now in 2023 for antibiotic stewardship in the Indian Health Service? Well, we roughly 9 years ago, we created a national Indian Health Service antibiotic stewardship program. And one of the big focuses of this group was early on to create national antibiotic guidelines to give advice to those 574 tribes across the country and many, many facilities. We created a core formulary, drugs that are recommended to treat different infections, and we release what are called formulary briefs to teach providers, nurses, and other public health workers about antibiotic stewardship, and then do a lot of educational activities. And I'll kind of cover these things in the next few slides. So they're focused on pharmacists and providers. So let's go to the next slide, please. So how about those national guidelines? We started doing them around 2014. These covered comprehensive recommendations for common illnesses. We last updated these in 2020 for inpatients and 2021 for outpatients, and they have not been updated since, in part because of the pandemic. What we do is to link a best choice drug for each common diagnosis based on local resistance patterns. So we understand that a large entity like the Indian Health Service covers the whole country. You can't have one specific drug for every indication that applies to the entire country. So there are regional differences. So obviously the big challenge, antibiotic susceptibility varies greatly across the Indian Health Service because we cover such a large area. And secondly, guidelines quickly become outdated over time. So it's very challenging to keep up when you have a large institution such as ours. Next slide, please. So what we do, we have a National Pharmacy and Therapeutics Committee that has a formulary. We call this a core formulary, saying that any drugs that are on this formulary are mandatory to be carried at every pharmacy in the Indian Health Service, whether it be inpatient or outpatient-based place. And it's tightly regulated by a team of experts. They're subject matter experts who meet quarterly from across the Indian Health Service. They talk about everything, cancer, urology, diabetes, but they focus a lot about antibiotics because of the stewardship concept. So they provide important formulary briefs to educate the teams across the country. And they also have sort of a best practices in formulary management process to improve stewardship of antibiotics. So they want to focus on these important DHHS goals of access, quality, value, and equality. So our patients in the Indian Health Service get just as great care as patients who are in tertiary care centers in big cities, even though they live in very remote rural places. Next slide, please. So what about these formulary briefs? These are created to address current needs. So for instance, recently briefs have dealt with upper respiratory tract infections, sexually transmitted diseases, and COVID-19. So if you look to the right, it's in fine print, but it basically talks about 3 diagnoses: otitis media, streptococcal pharyngitis, sinusitis, and bronchitis. And they give specific guidance on how to treat, which antibiotics to give for those 3 common infections that require a treatment. But they state that for bronchitis, a cough, that patients not get antibiotics. And then in yellow highlighted, they make a statement that for these URI categories, 90% are viral etiology and do not require antibiotics. So these briefs go out in one click to hundreds, if not thousands, of providers across the Indian Health Service and pharmacists to educate them about what's the latest guidance on treating these common infections. Next slide, please. In addition, the antibiotic stewardship program has done lots of education. So this is just the schedule from 2022, where the pharmacists had a monthly webinar focused on various topics, including the core elements of antibiotic stewardship, sexually transmitted illness, antibiograms, ambulatory care and emergency department, basically hotspots where antimicrobial resistance can arise if you're not very, very careful. These were monthly webinars, and they were very important in educating pharmacists. Next slide. In addition, for providers, we did something different. We have been collaborating for the last 10 years with the University of New Mexico in a group called Project ECHO, E-C-H-O, which makes it possible to do complex medical care at very rural sites in Indian country. So instead of having a person drive 150 miles from an indigenous nation all the way to a big city like Albuquerque, the patients are allowed to see their own provider in their own home community, and that provider links up monthly to a professor at the university or experts within the Indian Health Service to discuss the care of that case. So starting in 2021, we created a infectious disease echo. Previously, we simply did HIV, tuberculosis, hepatitis C, but this was designed specifically to talk about infectious diseases, covering things like urinary tract infections, sexually transmitted illness, TB, HIV, COVID, Mpox, endemic fungi, and drug-resistant organisms. So in this format, somebody will give a lecture. In this slide, you can see a famous person just to the left on that grid there, the left central area. And we would hear a lecture, then we would present cases and discuss those cases. So we found this to be a very effective way to bring state-of-the-art care in stewardship to very remote sites, very far away from urban centers. Next slide, please. So something happened in March of 2020, and this was the COVID-19 pandemic. First started to show up in Indian country in mid-March of 1920. And by April 2020, we were heavily impacted. On April 23rd, the Navajo area Indian Health Service was featured in a story in the New York Times showing that we are one of the most heavily impacted places in the entire country. And you'll see in this picture some of my colleagues who are hospitalists and nurses on their day off, volunteering to deliver care to persons who had COVID-19 at local motels, who were too healthy to be in the hospital, but too sick to be at home. So they got their care right in those motel rooms you see in the back there. So this took up a lot of our time. Since the pandemic began, we've treated a total of 570,000 persons for COVID-19. We've given out 2.6 million vaccines. And thanks to groups like ASPR, we've been able to deliver really state-of-the-art care. So we were one of the first groups in the entire United States to get the original mRNA vaccines out to our population right after they were approved by the FDA within a week. We also have had great access when they were useful to monoclonal antibodies. And then we continue to have excellent access to antivirals through our federal connections. So the story in Indian country is that we were very busy with COVID-19. Things are better now, but we are still recovering from the pandemic in terms of antimicrobial stewardship. Next slide, please. So basically, the pandemic diverted staff away from routine care. We saw a temporary decrease in tuberculosis and syphilis, followed by a resurgence once clinical services and surveillance reopened when the pandemic lightened. And staff had to be educated during these months about how to avoid overtreating COVID-19 patients with antibiotics. There's a big temptation when a doc sees extensive infiltrates and pneumonia to assume that it's bacterial and that an antibiotic is needed. We had to help encourage doctors to treat these as viral pneumonias, to focus on the SARS-CoV-2 virus. Next slide. And this is our last slide. What about the future in the Indian Health Service for antimicrobial stewardship? We are working as an agency to revitalize national stewardship program to update the update the guidance that we give to our providers as the pandemic response has subsided. Our ultimate goal is to have a stewardship pharmacist at every single facility in the Indian Health Service. So I'm talking all 574 tribes and multiple hospitals. We'd like to have a stewardship pharmacist at every single site. We have used regional antibiograms, and we'd like to make this national so that a person living in one particular region can prescribe antibiotics that reflect the local resistance pattern of the bugs that are present. And then we know that education is key. Antimicrobial stewardship doesn't happen in a vacuum. You need to be educating. So we're going to continue our ECHO teleconferences, these Zoom meetings that involve teaching and case discussion, and these stewardship program webinars, and then those all-important formulary briefs that teach the providers about antibiotic stewardship. So last slide, please. I'll close there with this beautiful picture from the Navajo Nation taken by my colleague, who's a photographer and muralist, Dr. Chip Thomas, working in the Monument Valley region. Thank you very much.
Well, thank you to all the presenters for an incredibly informative and engaging set of presentations again. I've learned a lot. I think there are a lot of really interesting cross-cutting themes and really learning about, I think, Dr. Campbell described the Federal Bureau of Prisons as the largest unknown health system in the country. And I think today we can think a lot about those people who might escape capture in some of the ways that we typically talk about stewardship. So grateful for the presentation. So we'll turn now to council question and answer. And I see we already have some hands raised. And I'm going to go by the order on my screen here with Dr. Dodds-Ashley for your question.
Thank you so much. As with all the presentations today, these have been super informative and shedding light on areas we honestly probably don't practice a lot in. I did have a question though for Dr. Campbell, as well as Dr. Rodriguez, and I think is on the call for questions. I'm a pharmacist who practices within the Duke Health System here in Durham, North Carolina, and we have a federal prison not far away. And I know that especially during the early phases of the pandemic, we ran into some challenges in that shared care of patients who would come to our health system. And so as we think as a council about recommendations to put in a report about being best prepared for future pandemics, I wanted to ask you, what are the places we missed? I think specifically of several cases where, because you are your own jurisdiction, there were differing criteria for use of remdesivir, and sometimes there were patients transferring to us that were started in the prison on remdesivir, but didn't meet our hospital criteria at the time, et cetera. And I'm just wondering about, there were always issues around transfers of medications, et cetera. So having now, as we emerge from the pandemic, what would be helpful for us to consider and recommend, and what are we not thinking about to prepare the Bureau of Prisons for a future pandemic?
Yeah, it's a great question. And I think you mentioned transitions of care, and that is certainly a huge one. Throughout the pandemic, we still were legally and morally obligated to let our patients release back to the community when their time was served, and to bring them into our custody when and if that happened. And there was a lot of communication at the beginning about, well, what is the Bureau doing to get these guys out, and or girls, or what have you? What is the Bureau doing to release them? Why are they keeping so many incarcerated? And the fact is that incarceration is a legal obligation of the United States at this time. So I felt sometimes the message was missed, where certainly there were opportunities to look at ways to release them back to the communities, but that wasn't going to work for a majority of our patients. So we needed to look at how to manage them within the confines of the institutions that we operated with, and how to communicate that with the community. So for instance, vaccinations. We had to establish an entirely new system to update our patients' vaccination status so it would be viewed and accepted when they were released. So we've always maintained an internal process for vaccination, documentation, and reporting. But to make that viewable and accessible in the community was a huge hurdle for us that we had never had to address before. I think another thing people forget is that we do have a significant security component. So we can't make patient-specific information publicly available at all times. We have significant reasons for that. We have WITSEC units, and we have patients that are under protective custody and worrying about their safety and not needing, and their victim safety, that they don't know where they're housed, that the persons that are housed don't know where their victims are. There's a lot of things that come into play with medical records that people don't consider. So we can't have this open file sharing that we would hope we could do to improve transitions of care. So I think in the future, increased communications and access to communications with community partners, planning ahead. We generally try to plan as far out as possible before a patient releases. So, we recently did an audit where we were looking at Medicare, access to Medicare and Medicaid for our patients when they went back to their home states. And a lot of the states had never thought about, well, how do we get, previously incarcerated patients access to Medicaid when they get back home? How do we make sure they have that on day one when they're back in the community? So I think continuing to increase the narrative of considering these persons who really have been separated from the national, I don't want to say healthcare system because we don't have a national healthcare system, but from generally community accessible healthcare systems, thinking about that process. And certainly the ability for the Bureau to be recognized as its own jurisdiction was a huge, monumental hurdle for us. And as terribly difficult as COVID was on our agency and the country, that's something really good that came out of it. It's open communication to look at how we can start employing other vaccination programs to make those accessible to patients when they release, and their records accessible, and having that data available. So that's a very roundabout way to answer your question, but I hope something was helpful there.
Thank you. And I do want to note that Dr. Wilkins has to drop off at 2 p.m. for another meeting. So if anyone has questions for her, please make sure to line up. But we'll move to Councilmember Dr. Fate now for another question.
So I think certainly all the panelists and I would imagine the members of this council would agree that it's important that we collect, analyze, and share data on various demographic constructs, racial constructs, whatever they are. But I think there are still members of the public, and I've run into them in my profession, who think that asking what gender you are or what race you are is highlights a problem that shouldn't exist or doesn't exist or whatever. So I would like the council to consider or make sure that we address that in our report, that those kind of data, if we don't look for them, we won't find them. But I also would invite any comments from any of the panelists about that particular issue.
Yeah, thanks for the comment and the urging. I certainly agree. The Joint Commission requires that we collect data on race and ethnicity. That's been a requirement for a long time. We can say a lot of people are not meeting that. So, but for the health systems, and then, starting January 1 of this year, there's a new Joint Commission requirement that we are collecting data, social determinants of health data. So, I think from a health system perspective, these are things that we should be doing, and it's unfortunate that it's not done systematically as well as it should be. I think there are, though, some inherent problems, not just from the standpoint of, public views on, whether or not we should be collecting the data. As I mentioned, the way that we're capturing race and ethnicity now is not how people necessarily identify themselves. And so we need to move towards a different approach, and, one that we have proposed and is being used in the All of Us research program, the Precision Medicine Initiative, also in many health institutions, including at Vanderbilt, where we're moving to a one question that ideally would say which of these best describes you, and doesn't actually use the words race or ethnicity, because there are different beliefs about that as well. And ideally, again, that branches into other groupings that you can identify ethnicities or subgroups there, so that we can really understand the diversity and different experiences that people are having. Part of what we're doing, as we've just updated the options in our Vanderbilt, in our EHR Epic, is we're doing this "We Ask Because We Care" campaign. It's modeled after Henry Ford and others who've done this. Why are we asking the questions? What will we do with the information? And also reiterating our efforts to keep individual information private and confidential.
Any of the other panelists from the session want to comment at all? You have a chance now, or else we can go to Dr. Blazer. Okay, Dr. Blazer, go ahead.
Great, thank you so much. I'd like to thank the panelists as well for giving us a very broad view. As was said, there is no health system in the United States. There are a lot of different fragmented systems. And so on that line, I'd like to ask a question to Dr. Iralu about the Indian health system, because as you point out, it has certain advantages and disadvantages. I was surprised by the scale. It sounds like it's about 1% of the size of the United States. So it really could be a model system in many ways, especially it's got a single payer, et cetera. One of the things you mentioned earlier is that there were findings that in people who had community acquired MRSA, it was associated with increased antibiotic prescribing. And that's really a very important concept, because it's not just prescribing for staph infections, it's prescribing for any infection. And I wonder how much the care community in the Indian Health Service understands that, and whether that would be a good message to come out. Because then you talked about the national formulary, where you were trying to make recommendations about what's the right drug for particular infections. But to me, that's the secondary question. The primary question is, does this person need an antibiotic? And I think that's not a question that is best answered by a pharmacist. Putting a pharmacist in all places may not it's kind of like rearranging the deck chairs on the Titanic. We need to cut down on the overall extent of that. And so, in this, we'll call this the inter-pandemic period, here's a chance to get all the ducks in a row so that, antibiotic prescribing can get optimized to reduce resistance and other issues. I wonder if you could comment about it.
Yeah, Dr. Blazer, you are absolutely correct. In fact, when we gave people report cards, we tracked their usage not of beta-lactam drugs like cephalexin or dicloxacillin. We track ciprofloxacin prescriptions. So the higher your ciprofloxacin prescription rate, the worse, the bigger the risk that the individual provider's patient would develop MRSA infection. So getting those kinds of report cards to people is invaluable. We've used them throughout the years to try to avoid overprescription of antibiotics for rhinosinusitis, et cetera. But we have our current EMR doesn't make it very easy. It requires extensive programming just to do a simple project like, say, to give feedback on prescription of antibiotics for sinus infections, et cetera. So it is challenging, but it's very valuable.
I wonder if I can just follow up on that, because you mentioned that in the COVID epidemic, there was a lot of prescribing of antibacterials for viral pneumonia, and that you were working on trying to get doctors to prescribe less. And so my question is, how well did that work, and what worked and what didn't work?
Oh, so we simply do that through teaching. We do not collect data on that topic. We were focused so much on doing COVID care delivery that we did not track antibiotic prescription during the pandemic. And that's a weakness. It's something we'd like to recover now in I hate to use the word post-pandemic, but this pandemic interim period where things have quieted down a bit. So.
Great. Thanks so much.
Yes.
I'm going to take moderator prerogative because I have a question for Dr. Wilkins. I'm going to jump in line before she has to leave. I was very fascinated and appreciated the point you made about the unknown race group and the fact that that group had, more disparities and inequities than those who had a race selected. And I'm curious if you could talk a little bit more about any follow-up you did to sort of understand what was going on with that group, or how you sort of remedy and address that, right? Because we've learned a lot that what gets measured gets managed, and if you're sort of missing, you can get lost. So I'd be curious if you have any concrete suggestions about how that can be addressed. Thank you.
Yeah, thanks. I'm also very interested and fascinated by the group. We were trying to make sure, one, that we were taking people out of that category who said that they did not want to disclose. So they're actually in a smaller separate category, but may have some similar characteristics. And so the unknown race group, when we looked at some of their other sociodemographic factors, actually more than half of them, their preferred language is something other than English. And so we believe that many of these individuals are, perhaps born in other countries where these racial and ethnic categories are different. We know that outside of the United States, many other countries only refer to ethnicity and not race. And so the actual, question itself might be confusing to people, or, these broader categories like Asian might not resonate with them, because they identify as Japanese or, some other, Asian ethnicity. So, but the first thing we saw was that they tended to have preferred languages other than English.
Great, thank you. All right, we'll get back into line. Dr. Fate, you're up.
Thanks. This is, I guess, for Dr. Irilu, and then perhaps the Bureau of Prisons. And Joni knows I have a thing for guidelines, so I always have questions about guidelines and implementing guidelines. And my question is about the formulary documents or guidance that you have developed, are those available at point of care, like within the electronic medical record system, so that if you've made a diagnosis, then that sort of appears, the info button sort of thing that is my dream in veterinary medicine, but will probably never happen because, or at least not in my lifetime, because we don't have the same kind of electronic medical record consistency as is possible in human medicine. But so what does that look like, at the point of care, those guidance documents?
Sure. Irlu, I can address that briefly. So we have a fairly standard methodology, but it has to be implemented separately at each individual hospital, where if you click on a diagnosis, for instance, adult sinusitis, and it will tell you what the first choice drug and the second choice drug is. And these are carefully reviewed every year by the Antibiotic Stewardship Committee to make sure they match the current guidance from the ID Society, and also that they match the local antimicrobial resistance patterns. And they even include things like they tell you, do not treat this infection with antibiotics. So we have some of the diagnoses, they will say gastroenteritis, community acquired, not sick enough for the hospital, do not treat. So that is the drug that you get to order, just do not treat. And then they in addition include some other things that are helpful for stewardship. For instance, if someone is treated for Helicobacter pylori, the order for the test of cure is built into the order set for the drug that you've prescribed. So you basically have sort of like and if you order a treatment for gonorrhea, you can do the test for reinfection in 3 months built right into the order set for the antibiotics. So it's kind of like a public health approach built into the EMR, but it requires all kinds of complicated programming because we have a very old EMR.
Yeah, so we are very similar to IHS in that we do have our own EHR that was developed specifically for the Bureau. And clinical decision support is something we continue to work on, similar to that, where when you select a diagnosis, it can walk you through steps. And we're not there yet. Currently, our process is, and we have the same EHR across the Bureau, it's the exact same system. And so when a medication is ordered for a specific diagnosis, if that diagnosis has been approved by our Antibiotic Stewardship Committee through the National Formulary, they'll be able to order it with no further steps needed. If that diagnosis has not already been approved, it will defer them to a non-formulary process where use criteria will be listed. So have you done A, B, C, and D? That request gets referred up electronically, and our Antimicrobial Stewardship Committee then reviews those requests.
Dr. Apley? I think you're muted.
There we go. Thanks. I see Dr. Ginocchio is right behind me, but I'm going to ask a question on diagnostics. So for all the panelists, I'm curious if your method of deciding which tests will be used and reimbursed within your system, if that is different from other healthcare structures. I'm interested in how that has affected your use of tests, if that's been a benefit or a detriment to you providing the care, especially in the context of AMR, and then how the use of those tests has affected what you see as the AMR challenges in your system. Dr. Irulu,
I'm not involved in.
Go ahead. Yep.
At Vanderbilt, I'm not involved in the testing for AMR, so I couldn't speak on that.
Okay, thank you.
So earlier here, so on a national level, our administration has to worry about things. For instance, if we realize that we're having an outbreak of something, for instance, a sexually transmitted illness, and want to implement screening procedures that are broader than what's recommended by the U.S. Preventive Services Task Force, we have to actually approach CMS to discuss this kind of thing, because it does go outside the usual practice. So we do have to think about that. But in terms of individual testing, the sky's the limit. We have strongly recommended implementing rapid diagnostic testing for methicillin-resistant Staph aureus using a PCR-based platform that everybody uses in the country now, thanks to the COVID pandemic. So we are able to implement that kind of technology and then just bill as appropriate. But big things that go outside the guidelines, you do have to ask in the federal system.
Yeah, so we have an internal network of labs at our medical referral centers that do a majority of our standardized testing. Anything else we contract out to an outside lab. So sometimes really our providers have full authority to order what tests they would like to. Clinical decision support would be nice because it might direct them to do tests that may be appropriate for the diagnosis that they're considering. Sometimes there are tests, and I think Lieutenant Commander Campbell would agree, sometimes when we get requests to review non-formularies or review patient morbidity cases, we wish certain tests had been ordered and they weren't. And so then we're trying to go back and speak to providers about this would assist with this diagnosis or assist with determining the best course of treatment. So it kind of goes both ways, but we certainly, I think some clinical decision support. Not everybody can know everything. There's a lot out there. And at least in the Federal Bureau of Prisons, which I'm sure like a lot of healthcare systems, we see, I think, everything with at least one patient through our system. So any of those resources that are readily retrievable and accessible to help guide decisions, not make them, but guide them and give that information is helpful.
Dr. Ginocchio?
Well, thank you, everybody. It was interesting. Thank you, Mike, for beating me to the punch on my first question, but that's okay. And I just want to make a comment to Dr. Rodriguez first about the clinical decision programs. In our healthcare system, when we switched over to one of the major new hospital information systems, and we went to all pre-ordered sets depending upon the admitting diagnosis, we decreased laboratory testing by over 30%, and it actually greatly improved clinical care because the residents, don't go down the line and check all the boxes because they don't know what to order. They actually ordered the right test. So I highly recommend if you could get that put in, it's really great. But the other question I have for you is, on Dr. Campbell's slide, he had shown one of the incentives or the programs that you did was to try to educate on the proper use of antibiotics and administration of antibiotics. And we all do that on a regular basis. How successful we are can be challenged sometimes because caregivers will still do whatever they want despite our recommendations. So do you have any idea how successful that education was in the treating of COVID? What percentage were maybe inappropriately still given an antibiotic? I mean, you're in a difficult situation. I'm sure everybody's stressed for time. You have a lot of patients. You're in close quarters. It's all those things that make for it a very intense rapid decision-making process. So do you know how effective that was, or what percentage you think were still given an antibiotic unnecessarily?
I'll answer first, and I'll go to Lieutenant Commander Campbell to see if he has any additional data. He mentioned the issues of stigma and that kind of being bi-directional. So there is the stigma from the general public towards the incarcerated population. There's potential stigma of staff with the incarcerated population, but then there's the stigma of the incarcerated population with the medical care they're being given. There's an assumption that they're being given less than what they would get if they were in the community. And so we fought a lot with that. And I used to provide direct patient care. I don't anymore in this current position. I had so many conversations with patients about there is no medication to treat this. This is new. We're trying to figure it out. We can treat your symptoms, but we're not withholding. We're not, not giving you something that, and then they'd have family members call and said, well, I read that ivermectin cures COVID and they're not giving it to you because they don't care about you. So there was a lot of that. And it's something that we found as Lieutenant Commander Campbell mentioned, the health literacy level of our patients. Our patients come to us with a lot of their social determinants of health that mean that when they arrive to us, we're already at a disadvantage. And then not having communications at a health literacy level that was applicable to share with them was difficult. We'd find resources and those resources didn't look like them, didn't talk like them, didn't use the words they understood. Even CDC resources, and we've developed great communications with the CDC, but we told them some of this stuff doesn't work. Our patients are in here. This is a joke to them. Not taking this seriously. So some of what we did, we managed through just formulary changes. There were times where we just said, okay, azithromycin, we're taking it off formulary unless they have these very specific diagnoses, nothing related to URI, because it was so overused, especially at the beginning. And there were risks with azithromycin. It's not a benign drug. It's not something that we want to give to everyone. So Lieutenant Commander Campbell, I don't know if your team had developed any data or have been looking at any of that.
So what we had planned to look at was our fluoroquinolone use, because at the time during the pandemic, we were providing a prospective audit and feedback program on all fluoroquinolone prescriptions. And early on in the pandemic, we did see those numbers start to tick up. However, kind of as we developed a little more concrete internal guidance on how to manage our COVID patients, that kind of leveled off and kind of went back to pre-pandemic levels, that the interventions we had been making were effective. It was about a year ago that we went back and we're going to kind of look and see over the 18 months kind of what our trends look like. Kind of similar to what was mentioned within the Indian health system with extraction of data. It's kind of difficult within our system to get data, and data that we can be confident in is reliable. So we don't actually have any concrete numbers, but I just can kind of say that through that prospective audit and feedback program, early on we saw a huge uptick in use of at least respiratory fluoroquinolones. And as we educated providers, both on that institution level where we'd see orders creeping in from institutions, and we'd have that one-on-one with the doctors at those institutions saying, hey, we kind of, after I would say the first 2 or 3 months, those became fewer and fewer. So it did seem effective, but I don't have any real hard numbers to really back that up.
Thank you.
Any other council members that have questions? Not, we can wrap it up, and I can turn it over to Jumana.
Thank you, Julie, and thank you folks for joining us today. Again, another fantastic afternoon. We appreciate your insight as the Pandemic Preparedness Working Group takes all of this feedback into its development of its upcoming report. So we typically have an innovation spotlight reserved for this day, but I think given the nature and the topics of these 2 days, we don't have anyone signed up, and the ones that have signed up couldn't join us today. So we are happy to just keep moving on and give you guys your afternoon back. I'm going to turn it over now to Dr. Blazer, if you want to say a few words. And we did a little bit of a round robin yesterday, and you're welcome to do that today so we can get an additional council insight before we adjourn. Dr. Blazer?
Yeah, thank you, Dr. Musmar. Thank you, Jumana. We've had a great 2 days, lots of interesting material quite different than we've seen before. And I think it would be useful to have a round robin for people to go around and talk about what they've learned either in the 2 days or just in the last day that they kind of want to put into the record, and they want to spur other people on the committee to think about their ideas. So let's see, I see the first hand, Dr. Christine Ginocchio, and followed by Carla Houston. Mm-hmm.
Thank you, Marty. I can't say enough about all the sessions this morning and this afternoon. I personally think it was an eye-opener about a lot of these different disparate groups that really needs to be addressed, and hopefully in the next guidance that we're going to set out. It certainly highlighted the inequities in these populations, but how during the pandemic, different groups were able to address these needs, and how we just need to keep pushing that forward and promote policies as a result of this, that it doesn't get lost outside of the pandemic effect, okay? There's such great ideas and things, but it takes money to support programs and other things, so let's not forget about them now that we're outside of the pandemic. We really need to make them sustainable. Key things that we talked about throughout the whole thing: communication, by key components. They need to be timely and they need to be accessible. We need appropriate socioeconomic surveillance to make sure that we're not missing out on certain areas that need to be addressed, and address upstream, downstream factors, all those hidden inequities that we may not be aware of. And I think I left with a very good appreciation for the very difficult groups. Having been in the hospital setting for almost 50 years, everybody has their issues, but I think these groups bring very specific issues to light that, we may have our own, but it doesn't compare to some of these in these underserved populations, which I think everybody did a great job in explaining those. And I want to congratulate everybody. Thank you.
Great. Thanks so much, Christine. Next up is Carl Houston, and Julie Simzik will follow.
Hey, thank you for the opportunity to speak. I'm kind of a sandbagger, so as I was listening to the last 2 days of talks, which were excellent, and I will mimic what others have said. These were probably 2 of the best days that that I've heard since being on the committee. I'm reflecting upon communication, and as a representative or liaison to the extension veterinarians, thank you for yesterday. I feel like it was a big recruiting tool about the importance of extension. But at the same time, what I was, pulling that together, the importance of extension, I think Dr. Cray asked Dr. Daly, how many extension veterinarians are there? And then there was also the question about how many are there any parallel groups in the medical field? And I know the answer was yes, but it also brought me back to February of 2021. And I'm sure we all remember that. I think that was my first PACCARB meeting. And they had Dr. Roger Rennekamp, who is the director of health for Extension, speak. And there's a disconnect because nobody mentioned Extension's role in communication in human health yesterday. And honest, I never knew that role existed. So that pulls us back to the importance of Extension and outreach, especially when it comes to vulnerable populations, migrant workers. We do a good job or need a better job in making our materials bilingual. And also, I was reminded today about making sure that we can correct misinformation, and again, to different populations, because we do have to overcome some of those cultural barriers or some of those other population barriers that we have to think of. From an extension standpoint, again, I think our message from a veterinarian and outreach standpoint is to continue to support integration and coordination between groups among all populations, and continue that support, because everybody points to extension or our outreach or our education, but we have to funnel information to those providers in order that we reach the right audiences, if that makes any sense at all. I always say extension is great, but they've got to get the materials from somewhere. And again, it can include both animal and public health or human health. So thank you for letting me comment. And again, sorry it's so long. I've just been, thinking about the last 2 days as well as previous meetings.
Thanks so much, Carla. Julie Simzik, and next up will be Paula Cray. And Julie, thanks for moderating this afternoon's session.
Yeah, my pleasure. I think a big takeaway that spanned both days when we're talking about communication as well as we're talking about equity, disparities, and vulnerable populations is the critical importance that I think needs to be addressed in our report of access, whether it's access to factual information, access to protective equipment, access to therapies. You know, I do a lot of antimicrobial stewardship research in healthcare settings, and we tend to bound our focus on the clinical encounter, but there's a lot that's happening before the clinical encounter. There are people who don't make it to the clinical encounter. There are people who are getting antibiotics from other places that are not connected to the clinical encounter, and that when we think about the issue of antimicrobial overuse and stewardship, that we need to expand our focus, not only to measure what's going on outside of those easily capturable moments, but also like supporting people in getting access to things to help prevent bad outcomes. I was very interested in the Project Echo, ID Echo that we heard about from Dr. Irolu. I think we heard about a lot of interesting, you know, solutions or potential programs that exist that I think we should consider integrating into our report. So access, access, access. Thanks.
Great, thank you. Paula Cray, next up will be Paul Plummer. Paula?
Thank you, Marty. I think we've heard over the last 2 days some extraordinary and exceptional presentations that have been very different than what we've heard in the past PACCARB meetings. Yet throughout these presentations, I almost universally see some common themes, and one is still a call for surveillance. So regardless of who we hear from, we hear the need for surveillance in that particular area. More data, more information, continually tracking populations. And I'm wondering if we wouldn't put all of this together and make some kind of recommendation that that implementing surveillance, that the cost of implementing surveillance would be much greater than the cost we have right now of healthcare. And this might be something that we should look at. Nonetheless, we should continue to keep surveillance at the forefront of our themes. One other theme from the last 2 days was the continual mention of the need for more frontline workers, doctors, staff, pharmacists, nurses, social workers. I mean, this almost every presentation, that plea came through, and I think this is this really speaks to, if we're going to try to change the direction of education, if we're going to try to look at programs that might help society in general and how to steer students in the future toward careers that certainly will be employable, healthcare continues to be at the forefront, as well as healthcare related fields. And finally, just with comments that have just gone on, it came to mind that we continually mention new programs every time we have these presentations. Acronyms for something, some new idea, some idea program, acronyms I can't even remember what they stand for, but I bet you every word has an acronym associated with it. And this just reminds me of the need to find some way to aggregate all of those programs in an area where we can screen for them. Could we screen for something more easily, readily, quickly on diversity? Could we look at disparities amongst minorities? Could we look for X, Y, and Z? We look for menus for food without even thinking about it now. And yet in healthcare, it takes an inordinate amount of time and effort to find a little piece of information that would be invaluable in the whole process. With that, I thank you, and thank you for the time.
Great. Thanks so much, Paula. Now, Paul Plummer's up, and followed by Stephanie Black.
Great. Thank you, Mari. And again, I echo my appreciation for the speakers today. As I, sit back and reflect on the last 2 days, and then also thinking back to the last PACCARB meeting we had there in DC, I think I ended my round robin comments at that meeting talking about the importance of communication and the importance of trust and in these relationships. And I think obviously communication was a key component of our talks for the last 2 days, but I think really driven home through that process was how important communication is, and that how that communication impacts trust, but also how trust impacts receipt of that communication. And so as I was thinking about, kind of themes that have bubbled up to me repeatedly over this period of time, again, reiterating that communication, that trust. Building on that, though, I think two themes that I saw spoken in some of the talks, spoken outright, but in the others, maybe a little bit more undertone, are the importance of relationships and understanding the context. And so, particularly today, I think personally, at least for me, I think this may be true for a number of us. The kind of unique thing we've heard repeatedly, these were unlike other talks that we've heard. It was new context to different environments, to different marginalized groups, to different unique systems. And so it's that context that brings the richness of the complexity of this out. And so the relationships that we need to build to understand that context, and leverage to understand that context. So the challenge, I think, for us as a PACCARB, committee is how do we develop, recommendations, concepts that are of the scale that PACCARB has to do on a national level, but then really draws out and appreciates and emphasizes the importance of understanding, having those local relationships, understanding the context into which all the different contexts into which our recommendations might have impacts, and then how do we communicate it into those spaces? So appreciate the opportunity to make some comments.
Great. Thanks so much, Paul. Stephanie Black, who'll be followed by Mike Apley.
Thank you all. Thanks for the opportunity to comment. And as others have said, these cross-cutting issues of both communication and health equity were great to hear about. So I just wanted to highlight, I think, what Timothy Jenks brought up at our last meeting about the issue of addressing equity, which I think this meeting went far to do, but the idea of that we need to shine a bright light on healthcare inadequacies and the structure and systemic issues that we've heard about today. And I guess I wanted to highlight in particular the idea of thinking about, since data for action is so helpful, what are those health equity measures, that we can follow up on, that we could suggest? And I think that's something more for the council to think about. Certainly gathering that data in various conditions is important, but we all know that that's underreported. And in the health department, we're looking at doing imputation, using other ways to learn race and ethnicity, but also important to take into account that what we capture right now for ethnicity is inadequate, as was just mentioned in these recent talks. So new ways to even look at ethnicity. So I think all of these are really important issues, and thanks to the council and the speakers.
Mike Apley, followed by Michael Craig.
Thanks, Marty. A big full 2 days with a whole lot to ingest and digest. I kind of had four major things that hit me, and one is becoming really aware of some of the health inequalities that are out there, and very educated on that in the last 2 days, starting to be educated. And I think as we write a report, we need to make our case that those be resolved for two reasons. One is it's right and just that all people have access to the same high quality care. Number one. Number two, from another way of looking at is, as a population guy, I view with great skepticism anytime someone uses the term isolated populations. I'm not sure there are any. And so when you look at removing care or not having adequate care for a subpopulation as part of a larger population, we can't adequately address AMR or any pandemic if we don't address every corner of the people that we serve. And so it makes not only sense from a moral standpoint, it makes sense from a population disease control standpoint, and it also makes sense economically. The story about the organ transplant patient at home that went into sepsis because they couldn't afford to go to the dentist. And I remember years ago our presentation on the program where they sent out a dental health care kit prior to surgery and what it did to drop the surgical infections. And I think I was sitting next to Dr. Boucher at that one, and she commented that, how much they have to spend pre-transplant to send some patients to get their mouth cleaned up before they can do the transplant. So just basic care is important. And then number 2 on communication, I've had my view of communication changed. I always thought of putting out education in language that I understood, and it made me understand that a lot of that is wasted if it's not in the language. And I'm not just talking about English versus Spanish. I'm talking about the language that the group would understand. And Paul used the word context a minute ago. It's got to be the right language in the right context. And so that was educating to me. Number 3, I think we can get a lot more radical about hitting misinformation head on, a lot more aggressively. And I'm not sure how nice we have to play. There's the ivermectin deal for COVID in my world just drove me nuts. And I think we could have been more aggressive. And then the last thing is I wrote down 2 times I heard the need for decision support, and decision support beyond just the groups that are able to afford that decision support. And the word funding was used in context of decision support. But our underserved populations are not only the patients receiving care, we also have underserved populations in veterinarians, physicians, other health associated personnel providing the care. So I think we need to move our context from just the patient to also underserved healthcare providers that could be even better with more assistance. So thanks to everyone for a great 2 days, both to the panelists and to our council.
Thanks so much, Mike. Michael Craig.
Thank you, Marty. And thanks to everybody. Would agree, was a tremendous couple of days. I think that the bottom line for me across the 2 days is that it reiterates and brings into focus the challenges that we see every day, is that when we're dealing with these issues related to antimicrobial resistance, we talk about One Health and we talk about the importance of these things, but at the end of the day, those things practically mean, and when we look at the scope of these pathogens and the challenge of these pathogens, that they literally affect everyone. And that doesn't mean that they affect everyone equally. I think we've learned that they don't. And it also means that not everybody can address and deal with those things or has the resources to deal with them in the same way. And so when we think of, how do we address these issues on a national and international basis, on a state basis, on a municipality basis, on a farm basis, on a hospital system basis, or a nursing home basis, thinking through those pieces, it is very challenging and complex. And how do we provide resources that can do the most good, but also can reach these populations that we are missing? And I think that's a major consideration, and one that, I think we're trying to bring some thought to at CDC. How can we put out data that provides a big picture of what's going on, but also provides a focused picture of what's going on in other subpopulations and does that adequately? And I think it's one of those things where, I don't think any of us think, based upon what we've heard, that we're where we want to be right now. And I think we need to recognize it and take incremental steps or big steps if we can to get there. I think it's going to be a lot of trial and error, but I think it's one where we have to make progress and we have to get better at it each time. I think what Stephanie noted, that, you know, coming up with measures, we have some measures already, we should use those, but we also know those measures are inadequate. So I think we need to do what we can, but then also recognize the limitations of the things that we have now as well, and then incrementally work to improve them and get them better and better, and bring some of these things into sharper focus. So thank you all.
Right. Great. Michael, thank you so much. I don't see other hands, so I'm going to tell you my comment. And it's about communication. This whole meeting was aimed for communication, and I think we've accomplished a lot. The panelists, were very strong. They gave us lots of interesting ideas and lots of examples, and I think our council has taken up the bait very well. It's really been food for thought. So my concepts are what I might call Public Health 101. I never took Public Health 101, so I'm just guessing what maybe the new Public Health 101 should look like. And we all talk about communication. And by the way, by going last, I'm probably repeating little pieces of what just about everybody said, but it's my chance. So communicate. We know that communication is important, but it's clear that communication has to be based on trust. Because if people don't trust you, it doesn't matter what you're saying. And so the fundamental basis of communication is trust. And part of trust is equity and justice. If people believe that there's equity and justice, then they can trust. So I think that's some of the work that we have to do in the public health establishment, is to get back to those fundamentals. I've got 3 points. The first one is that we have to build relationships in the community, not just in our clinics and not just in our public health apparatus, but we have to make contacts with legislators and with church leaders and other community groups, so that public health it's not us and them. We are part of the community. Second, or the other part of that, as was suggested earlier today, is that we actually need to bring public health to the people. Not that the people come into the hospitals, that people come into the clinics, but that public health people are going out to the homes, as was suggested. They're going to the farms, like the veterinary extension, to the churches, to the barbershops, other ways, so that public health is part of the community. People will say, well, I don't really buy what the government is telling us. But, if it's Joe who's coming out to their home, or the visiting nurse, that's a different story. People trust that. And maybe part of the problem is that public health has gotten too far from the field. And that, I think, AMR is a great example, but it's again, maybe the canary in the coal mine of a bigger issue, which we saw with vaccines as well. So that's my comment. Does anybody else have comments they want to make? Well, we've had our round robin. Joanna, I'm going to turn the floor over to you.
Thank you, Dr. Blazer, and a sincere thank you again to all of our presenters and for everyone joining us today. It's been an intense couple of days virtually. So just imagine how it would be in person when we meet in March. We look forward to seeing everybody then. Thank you all to the team, especially for putting this all together. And we will see you in March. Be sure to check our website, HHS.gov/PACCARB, for all announcements and information about our March meeting coming up. More to come. Thank you. Have a great one, everybody.
And we have our work cut out for us because we want to follow up on the big advances from this public meeting.
Yes, we do.
So thank you, everybody.
Produced by the U.S. Department of Health and Human Services.